Aylin Reid. I am a neurologist and a clinician scientist at the University Health Network in Toronto. Today I'm going to be talking to you about post-traumatic seizures and epilepsy. My disclosures are that I have research support from CIHR, from the Department of Defense in the United States, and from the New Frontiers Research Fund. I do a lot of basic science work on post-traumatic epilepsy, but for the purpose of today's talk and for the audience here, I'm mainly going to focus on clinical things, so my disclosures are not really relevant to that. So I'm hoping that by the end of today's session, you will be able to identify risks of early post-traumatic seizures, describe the standards of monitoring for detection of post-traumatic seizures, appreciate the benefits and the limitations of treating these early seizures, understand the natural history of post-traumatic epilepsy, and describe candidate mechanisms of post-traumatic epileptogenesis and potential biomarkers for this disease. The traumatic brain injury is the leading cause of death and disability worldwide. There are about 100,000 head injuries a year in Canada. These mainly occur in working age adults, and the highest proportion of injuries occur in males, although there is some thought that this may in part be due to underreporting from females. Only about 18,000 result in hospitalization a year because most TBIs are mild. For example, concussion usually does not require admission to the hospital. Now, the leading causes of TBI in Canada are very similar to the United States. This graphic is from the CDC. It shows that falls, motor vehicle accidents, struck by accidents, and assaults comprise the majority of these injuries. And TBI are very important because they can have many physical, cognitive, and behavioral consequences, which can be very long-lasting for some people. So they can lead to motor impairment, headaches, cognitive impairment, including dementia, sleep disorders, mental health issues, and what we're going to focus on today, which is seizures and epilepsy. So TBI can be graded into different severities, usually mild, moderate, and severe. There are a number of classification schemes to categorize these different levels of severity, which most of them rely on any changes in structural imaging, how long the loss of consciousness and alteration of consciousness occur for, whether there's any post-traumatic amnesia, and the score on the Glasgow Coma Scale. But it's really these moderate and severe injuries that are at the highest risk for developing seizures and epilepsy. So seizures that occur after a TBI can be broken down into 3 different subtypes depending on when they occur. Immediate seizures happen within the first 24 hours after injury, early seizures within the first week, and late seizures occur more than 1 week after injury. And the reason that we make this distinction is that there are really different mechanisms causing these seizures. So we're going to start first by discussing these immediate and early seizures, which are really thought to be provoked seizures in response to the injury itself, as opposed to actual epilepsy, which we will talk about a little bit later. And again, these are important because they are often unrecognized, especially in an ICU setting where patients may be on ventilators, they may be on medications to suppress their level of consciousness, and so it can be difficult to appreciate seizures both in adults and in children, but it's still important to recognize them. Reports have shown that the incidence of these early post-traumatic seizures in adults can vary anywhere between about 2 to 17% of cases of TBI. And the factors that increase the risk of developing these early post-traumatic seizures, most of them really are related to the injury severity itself. So as I mentioned, a more severe injury is more likely to lead to post-traumatic seizures. And some of the biggest risk factors are things like a depressed skull fracture, hematomas, a penetrating head injury, lower Glasgow coma scale, so different things that are already contributing to a higher injury severity. And in a pediatric TBI, the risk factors are slightly different. So the mechanism of the trauma is important. It is known that abusive head trauma is a much stronger risk factor for early post-traumatic seizures than non-abusive head trauma. And in children, having the head injury at a younger age, so less than the age of 2, is also a strong risk factor for developing these early seizures, along with some other factors listed there, which again contribute to a more severe injury. So how do we detect these post-traumatic seizures? I mentioned that sometimes it can be difficult to do this in the ICU setting. The ACNS has put out a consensus statement on when it is appropriate to use continuous EEG in critically ill adults and children, and this includes patients who have suffered from a TBI. And so continuous EEG is recommended to identify non-convulsive seizures and non-convulsive status epilepticus in patients who have an acute supratentorial brain injury and altered mental status. And they note that patients younger than 18 may be at a higher risk than adults. And again, within the pediatric age group, it's the neonates and infants that may be at the highest risk. And looking at studies that have examined the incidence of seizures on continuous EEG in the ICU setting in moderate to severe TBI, in adults, it has been reported in 18 to 33% of the cases where continuous EEG has been done, whereas in pediatric studies, it ranges from as low as 14 to as high as 70% of cases found non-convulsive seizures or status on continuous EEG. The recording should be performed for at least 24 hours, recognizing there may be situations where shorter or longer recordings are necessary. And this is important to do when resources allow, because the typical 30 to 60-minute EEG recording will only identify non-convulsive status in about half of the patients who would eventually have a seizure if you actually recorded for a full 24 hours. So just doing that shorter recording is not necessarily sufficient to rule out seizures at other times in these patients. Now, this definitely is something that would be limited by resources and, of course, whether it is something that's safe to do in your particular patient. But we know that depth recordings with intracranial electrodes actually have a even higher yield than the typical scalp recordings. So there was one study that did implant intracranial electrodes in a neuro ICU setting in patients with severe TBI, and 10 of the 14 patients had electrographic seizures with the intracranial recordings. And the important thing here is that of those 10 patients, only 2 of them had the seizure activity correlating with ictal activity on the scalp EEG. So in these EEG tracings on the right, the green boxes show the intracranial electrodes, and you can see there is a seizure activity that is going on here. And on the scalp traces that are above that green box, you really would not be able to detect a seizure if that was all you had. So studies, again, have looked a little bit more at how helpful this is. And there was one study that did a post hoc analysis of continuous EEG in 152 patients that had moderate to severe TBI that had been part of the INTREPID study, which was to look at a growth factor to improve outcomes after TBI. And it was a negative study, but they did have this EEG data, at least to see the incidence of not only seizures, but other epileptiform abnormalities. And what they found was about half of the patients had patterns that they would classify on the ictal to interictal continuum. And of the most severe patterns, about 6% had lateralized periodic discharges, about 5% had generalized periodic discharges, and 12% had lateralized rhythmic delta activity. Now, they only found a rate of electrographic seizures of about 2.5%, which is much lower than the studies that I have shown you already, and many other studies that have looked at this in the ICU setting. And one reason for this may be that this study was done after some of the terminology for these other patterns has become more standardized. And it's possible that what others called electrographic seizures in the past may really have represented one of these other patterns. But the important thing to note here is that it's not only seizures, but other things like periodic discharges, which are on the ictal to interictal continuum that can occur as well. And so what can be done to prevent these early post-traumatic seizures from occurring? So there have been several studies that have been done. This was one of probably considered the classic study, a randomized double-blind study of phenytoin for the prevention of these post-traumatic seizures. And what they found was when they gave patients either phenytoin or placebo, they had significantly decreased seizures within those first 7 days after the injury. So 7 seizures in the phenytoin group compared with 26 in the placebo group. And there have been, other smaller studies and a meta-analysis that was done looking at the various controlled trials shows with this dotted line at the 1 here, anything to the left of that had a beneficial effect and anything to the right potentially had a detrimental effect. So phenytoin, the combination of phenytoin and phenobarb alone or carbamazepine all seem to be helpful. This study is older than levetiracetam and some of the newer agents. But you can see that on the right here, valproic acid actually appears to cause worse outcomes with phenytoin, and magnesium was not helpful either. So the American Academy of Neurology has practice parameters. They have pooled the class 1 studies and showed a significantly lower risk of these early post-traumatic seizures in patients given phenytoin prophylaxis compared to controls. The Brain Trauma Foundation also has guidelines for the management of severe TBI. And within that, they recommend with level 2A evidence that phenytoin is recommended to decrease early post-traumatic seizures within 7 days when the overall benefit is thought to outweigh the complications of such treatment. Because again, phenytoin is not necessarily a benign treatment. It can cause issues with other organ systems or interactions with other medications. They do go on to say that early post-traumatic seizures have not been associated with worse outcomes, and we're going to come back to that. And at the time of these guidelines, they said there was insufficient evidence to recommend levetiracetam compared with phenytoin regarding efficacy and toxicity. There are also guidelines for pediatric populations. And the studies there, which really had been a single retrospective study, showed actually increased seizures in the 15% seizures with phenytoin versus 53% if they didn't get any prophylaxis. So some support for this, but not as much as has been done in adults. So as I mentioned, the Brain Trauma Foundation says there's not evidence to use levetiracetam, but meta-analyses and some smaller studies have been done since then, which do suggest that there is no significant difference when using phenytoin versus levetiracetam. And it is being increasingly used because it is easier to use when IV formulations are available compared with phenytoin, and it does have a favorable safety profile. So many foundations have guidelines. The Neurocritical Care Society also has guidelines. And so one of their questions was, should anti-seizure medication versus no anti-seizure medication be used in moderate to severe TBI with no history of clinical or electrographic seizures? And I should say again, I want to make this clear. I don't think I mentioned it already. What we're talking about here with all of these guidelines is prophylaxis. So patients who have had a brain injury and have not yet had a seizure. Obviously, if they start having seizures, either clinically or detected on the EEG, then you're going to escalate your treatment and treat appropriately to get those seizures under control. But if they've not had a seizure, then this guideline suggests that you can either use anti-seizure medication or no anti-seizure medications. And they said that was a weak recommendation. So they think there's really low quality of evidence for that. If anti-seizure medication is used, they asked whether it should be levetiracetam or phenytoin fosphenytoin. And they are actually recommending levetiracetam because of an improved safety profile and tolerability. And then they asked, should it be for a long duration, more than 7 days versus less than 7 days? And they are recommending this for a short duration, for less than 7 days. So we have many guidelines. Some of them are a little bit different with others, particularly in which drug they are recommending. So how does this actually work in the real world? What are people doing in ICUs and in hospital settings? So this study looked at the practice patterns in the UK and the Republic of Ireland, and they asked physicians treating moderate to severe TBI patients, which anti-epileptic or anti-seizure medication do you use as your first choice for prevention? And more than half did not routinely use any seizure prophylaxis. And then the most common drug that was used was levetiracetam, followed by phenytoin and a small amount using valproic acid. And in terms of looking at what factors impacted their decision, it seemed to be a lot of things from factors that are found on imaging. So bleeding, skull fractures, contusions were some of the main things. And then again, 35% just said they would never use it. When asked how long do they continue it, again, 35% never, but most people, if they did use it, they followed the guidelines and used it for a total of 7 days. And 60% of the respondents did think that there was uncertainty or equipoise about whether seizure prophylaxis should be used in moderate to severe TBI in the acute phase. So despite the guidelines, some of which suggest using it and some of them which seem ambivalent can be used or not, many people still are not using this. And this is a study from Canada, from Ontario and Quebec, looking at whether there were any change in clinical practice after guidelines came out, and they really did not find any difference pre and post in the number of patients that received or the physicians that recommended seizure prophylaxis, which was quite low here. But they thought in this particular study, maybe a lot of the physicians were not aware of their particular guidelines. And again, the evidence for them or the recommendation was rather low, so people might not have thought that was a priority. Now, in pediatric studies, it seems this study looked not at whether it was drugs were given or not, but what was being used. And in many cases, phenytoin was still, or fosphenytoin, so the dark gray at the bottom or the slightly lighter gray right above it are phenytoin or fosphenytoin. So that was the majority, but there was starting to be in this light gray some levetiracetam as well. Now, one of the reasons that many physicians are somewhat reluctant to use these medications, and as the guidelines mention as well, is that the evidence as to whether they are helpful is not necessarily very strong. So both as to whether they actually prevent seizures, but also does it make a difference if we prevent these seizures? Does it impact outcome? So this study looked particularly in critically ill older adults who had a TBI. And in the graph there on the right-hand side of your screen, it shows the probability of death there. It's up to 7 days in patients who did not get any anti-seizure medication in red or who did in blue. And keeping in mind, though, that in this study, the majority had mild TBI, which is not actually what the guidelines are talking about. But the patients who did receive anti-seizure medication were less likely to die after TBI at all of 7, 30, and 1 year post-injury follow-up time points, despite there actually not being a difference in the amount of seizures between these two groups. So whether this medication was doing something else, I mean, it's hard to know. There are also, in the more mild injuries, a systematic review and meta-analysis that showed that the absolute risk reduction of treating these mild and moderate TBIs with an anti-seizure medication prophylactically was 0.6%, so much lower than the 11% absolute risk reduction that occurs when using these medications in severe TBI. And the number needed to treat to prevent one seizure would be 167 patients. So perhaps, further evidence that, especially in more mild injuries, this is not necessarily something that is very beneficial. So opponents of seizure prophylaxis will mention that there can be negative neurobehavioral side effects of using these medications. And that will depend, of course, on the patient and what their state is otherwise. And certainly some agents, perhaps levetiracetam, may have more behavioral side effects than others. They mentioned the questionable effectiveness in actually preventing early post-traumatic seizures. As I said, some of the studies didn't find any difference. And the questionable impact of what do these early post-traumatic seizures do to the brain and to the patient. So just wanted to touch briefly on some of the secondary effects of these early seizures that have been studied. So TBI leads to significant metabolic derangements, especially when it's a more moderate or severe TBI. It can cause decreases in oxygen metabolism in the brain, increases in glucose metabolism, and elevated lactate levels acutely, which is then followed by a period of metabolic depression. And this can lead to a metabolic crisis where you have an elevated lactate to pyruvate ratio in the brain and decreased extracellular glucose. And this occurs in more than 3/4 of patients that have a severe TBI and can last for many days. And this is usually measured by microdialysis, intracerebral microdialysis, to look at the extracellular components there. So this was a study done by Paul Vespa's group at UCLA, and they have done a lot of work on TBI and post-traumatic seizures. And they looked at intracranial pressure and the lactate pyruvate ratio in patients who had non-convulsive electrographic seizures. And these graphs, I took them from the paper. They're reversed here. On the left-hand side, we're looking at ICP, and we have the patients with seizures on top and the control patients, so TBI patients with no seizures on the bottom. And you can see there is a lot more variability and increase in the ICP in the patients that do have seizures. It kind of goes up and down episodically. On this right-hand side, we have the lactate to pyruvate ratio. So again, looking at these metabolic derangements. Here, the control group is on the top and the seizure group is on the bottom, but we can see again that there is a higher lactate to pyruvate ratio and more episodic increases there. So both of these suggest that the even non-convulsive electrographic seizures do have detrimental effects on the brain. Another study from this group looked at extracellular glutamate, and we have patients without seizures on top and with seizures on the bottom, and there were increases in extracellular glutamate caused by these seizures after TBI, and that can have detrimental effects with excitotoxicity and increasing excitability as well. Now, we had talked earlier about not only electrographic seizures, but also periodic discharges that can occur after TBI. And in this study, again, from the UCLA group, they had patients with TBI on continuous EEG and found seizures in about a quarter of them and periodic discharges in 38%. Some of these patients did have depth recordings again. And in 43% of them, the epileptiform abnormalities could only be seen on depth. So again, even with scalp, we are missing something with scalp recordings. Most of these abnormalities were ipsilesional on the side of the TBI. And the periodic discharges in the lighter gray and the seizures in the darker gray on that bottom graph, onset usually was within the first few days after injury. So they had done microdialysis in 20 of these patients. And what we see in this graph here, in this first gray bar in the middle, it's an epoch where the patients had periodic discharges. And then this lighter gray was an epoch where they called non-ictal, no periodic discharges. And we can see in particular that the glucose level was lower when these periodic discharges were occurring compared to the non-ictal epoch. And the lactate to pyruvate ratio was increasing during that time and then dropped again. So again, showing that even periodic discharges can affect the metabolic patterns in the brain. And this is just showing with each patient, when they were not having periodic discharges, what their lactate to pyruvate ratio was and how it increased when they did have periodic discharges. So suggesting that even periodic discharges are not benign after TBI. And that potentially treatment should be adjusted to try and improve this electrographic feature. They have also shown that there is a greater amount of hippocampal atrophy when non-convulsive seizures occur on the ipsilateral side, as shown here on this bar on the left of this graph. Compared to patients who did not have seizures in the gray bars on the right. We also know that the occurrence of seizures after TBI is associated with worse functional outcomes. So it is an independent predictor of patients having a longer hospital stay in both adults and children. It leads to a higher probability of needing to be discharged to a nursing facility, lower discharge Koschke scores, which are, again, a score of functional outcome, and it increases the risk of late post-traumatic seizures or post-traumatic epilepsy. So to sort of sum up the post-traumatic seizure section, early post-traumatic seizures can be common. Many patients, if they have seizures, they will be subclinical, and so continuous monitoring is recommended for at least 24 hours. Depth recordings do have a higher yield, so while I'm not recommending that they be done, it's just something to keep in mind that even with scalp recordings, you're not getting the whole picture there. Prevention with phenytoin for 7 days post-injury is still the recommended option in most guidelines, although levetiracetam does seem to be a very reasonable option as well. And to keep in mind that these early seizures are linked with metabolic crises, hippocampal atrophy, and worst functional outcomes. So when you are making a decision as to whether you want to give prophylaxis or not, that is something to keep in mind. So with that, we're going to move on now to post-traumatic epilepsy. And so these are the late seizures that occur more than a week after injury. And these occur in 3 to 5% of patients who have a moderate TBI and 25 to up to 50% of patients who have severe TBI will develop post-traumatic epilepsy. And of the patients who ultimately do develop post-traumatic epilepsy, about a third of them will have that first unprovoked seizure. So when the diagnosis of post-traumatic epilepsy can actually be made within the first 3 to 4 months after the injury. And the other 2/3, most of them will have their first seizure within 24 months. But as we will see, it can be much later than that. And it accounts for about 20% of, this is an old graph and sort of old terms, but 20% of symptomatic epilepsies and about 6% of all epilepsy is post-traumatic. So the risk factors for developing post-traumatic epilepsy, many of them are quite similar for the early post-traumatic seizures that we talked about. So a higher injury severity in adults in older age, greater than 65. This is actually the opposite from the early seizures. So in pediatric studies, older children, so those older than 15 are more at risk, whereas younger children were more at risk for the early seizures. But having those early seizures puts you at risk for post-traumatic epilepsy. And then some other things, that are part of the severity as well. So bleeding, contusions, and skull fracture. Now, I said many will have their first seizure within the first 24 months, but it's important to be aware that the onset of post-traumatic epilepsy can be many years after the injury, and studies have shown the risk can be increased for even up to 30 years after the injury. And so just a quick case, a patient that I once treated, a 46-year-old lady, she had a shrapnel injury in the brain when she was 2 months old. And she did not start having seizures until she was 38 years old. So decades later. She had seizures with loss of awareness, dystonic posturing of her left arm. She would do some gesturing with her right arm and had oroalimentary automatisms. And she could not have an MRI, but on CT scan, you can see on the right that she still has some metal in her brain. And then there is a lot of encephalomalacia going forward to the frontal lobe. And she came into the EMU, and probably for most of you, this is a little backwards. Right is on top of left. And we have a sort of AP bipolar montage with some transverse there as well. But she had a seizure that, as might be expected from what we saw on the imaging, that started over the right temporal lobe. But just to show that she didn't start having seizures till decades later, so it is possible. If you have a patient that you think has post-traumatic epilepsy, the diagnosis and workup is very similar to any other cause of epilepsy that you may see in your patient. So it's very important to do a good clinical history. And just because they have a history of trauma, that does not necessarily mean either that their seizures are linked to their trauma. So sometimes patients present with a generalized epilepsy. They have a history of trauma and it's thought that it's related to that, but they just have generalized epilepsy that is now presenting totally unrelated to the TBI. So they do need EEG, and if appropriate, they should have video EEG monitoring, especially if they are medically refractory, and imaging, including MRI and PET, as you would do in any other patient. It's important to know that there are high rates of pharmacoresistance in post-traumatic epilepsy, perhaps slightly higher than in sort of all patients with epilepsy. But despite that, there are low rates of referral to specialized epilepsy centers. In part, that may be because some of these patients have quite extensive areas of injury, and the thought is that, well, they're not going to be a candidate for any type of surgery because so much of their brain is structurally abnormal. But that is not necessarily always the case. Unfortunately, sometimes it is. The area is too large for any type of surgery, but they deserve, just like any other patient with medically refractory epilepsy, to be referred to a specialized center to have a workup to see if they may potentially be a candidate for a resection or for some other type of epilepsy surgery, such as neuromodulation. So please don't hold off on referring these patients to more specialized centers as needed. It's also important to potentially do monitoring to rule out non-epileptic seizures, because this can account for up to 25% of the cases after trauma. So Sometimes clinicians hear this history of trauma and of seizures, and they think, well, it must be post-traumatic epilepsy, and they don't necessarily entertain other diagnoses, but they still can happen. So keep that in your mind. The prognosis for PTE, as I mentioned, they do have slightly higher rates of medically refractory epilepsy. And if in the first year after TBI, the patient has quite frequent seizures, that is a sign that their epilepsy is going to be more refractory than someone who only has, rare seizures early after the TBI. The recurrence rate is close to 80% in the first few years after that index or first late seizure. And the rates of refractoriness can range from 23, but up to 53%, which is slightly higher than in sort of the general epilepsy population. So another case of a 42-year-old lady who had a motor vehicle accident and then started having seizures 7 years later with loss of awareness, right head deviation. They could be very brief, but sometimes she would develop right arm and leg extension and could progress to bilateral tonic-clonic seizures. And on her imaging, she had very extensive gliosis in the left hemisphere, as well as this large area of encephalomalacia, and involving sort of the temporal lobe as well. She came into the unit, and as expected, she had some left-sided discharges. Excuse me, but she did also have right-sided interictal epileptiform abnormalities, as shown on this slide. Now, her seizures that we captured were all over the left temporal region. But it is important to keep in mind as well that with post-traumatic epilepsy, we are sometimes dealing with multifocal areas of epileptiform activity. And that can be one of the reasons why some of these patients are not candidates for resective surgery, unfortunately. So we talked about preventing the early post-traumatic seizures. How can we prevent someone who's had a brain injury from actually going on to develop post-traumatic epilepsy? Unfortunately, there are no treatments to prevent the development of PTE. And there have been studies looking at whether giving these early standard anti-seizure medications that we talked about earlier, phenytoin, carbamazepine, phenobarb, and valproic acid could prevent epilepsy later on. And they really don't. And there are some other trials underway looking at other anti-seizure medications. I'm not so sure whether those are going to be any different. There's maybe some from preclinical work, some more promising data for levetiracetam. We'll have to wait and see. But the issue here is that with TBI, we have this period of epileptogenesis. So epileptogenesis is the process whereby previously healthy brain tissue undergoes a transformation so that it is now in a state where it is predisposed to generating spontaneous recurrent seizures. And TBI or PTE is an ideal situation to study the mechanisms that are happening during the period of epileptogenesis, because we know when the injury occurs. And so then we can study what is happening until someone may actually develop that first late seizure or their diagnosis of post-traumatic epilepsy. And it's a bit beyond the scope of this talk to go over all the potential mechanisms of post-traumatic epileptogenesis. But this is a figure from a recent review paper that I thought illustrated some of them quite nicely. So after the injury, there are disruptions in the blood-brain barrier. There are a lot of neuroinflammatory changes with increases in pro-inflammatory cytokines and chemokines that are released. Different immune cells are infiltrating the brain. As a result of this, there can be alterations in the function of microglia and astrocytes, as well as alterations to neurotransmitter receptors that can lead to hyperexcitability, and epigenetic alterations to these receptors as well as the deposition of tau, which is being investigated more and more for its potential role in epileptogenesis as well. So a lot of different processes that are, potential candidates for treatment to try and prevent epileptogenesis. And so preclinical work, especially, is going to be very important for moving forward with this. Sorry, I'm not sure if I'm going to wait 1 second for this announcement to finish. And this is why biomarkers for post-traumatic epilepsy are also very important. And unfortunately, we really have a lack of biomarkers to identify the patients that are at the greatest risk after a traumatic brain injury. So, as I mentioned, only about up to perhaps 50% of patients will develop a post-traumatic epilepsy. After TBI. And so we wouldn't want to give treatment to all of the patients that have had a TBI when only some of them are at risk of developing post-traumatic epilepsy later on. So it would be really useful if we could identify the patients at the greatest risk, and then when we have some interventions, give it to those patients. And so a biomarker is something that would help us identify patients that are at risk and also measure disease progression. And so there are some candidate biomarkers that are being investigated. Some of them are imaging biomarkers. And a lot of the results so far, again, have come from preclinical or animal studies looking at post-traumatic epilepsy. But there has been some promise from various types of MRI looking at blood-brain barrier disruption, particularly studies looking at inflammation and excitotoxicity to help predict which individuals will go on to develop epilepsy after a TBI versus those that won't. This is much harder to do these studies in a clinical setting because, again, with only a small proportion of patients developing epilepsy, and with the fact that they may not develop epilepsy for years or even decades afterwards, you need to enroll a lot of patients in these studies to be able to be powered to actually find these changes. There are also promising studies looking at EEG biomarkers. So I mentioned that the presence of epileptiform abnormalities in the acute phase increases the risk for the later development of post-traumatic epilepsy. And that really is more of a risk factor than an actual biomarker, because there's still many patients who will have these abnormalities who will not develop epilepsy. But a recent study looking at QEEG as biomarkers did find that the presence of electrographic seizures, generalized periodic discharges, an increased suppression on the EEG, and just epileptiform abnormality burden, they all seem to be predictors of the development of post-traumatic epilepsy. So as it's usually non-invasive, this potentially shows a lot of promise using EEG as a biomarker. Animal studies have shown that the presence of high-frequency oscillations and fast ripples can also predict the development of PTE, but of course that would be much more difficult to look at in patients. And then in terms of molecular biomarkers, there are also some promising things. One of the most strongest studies showed higher ratios of interleukin-1 beta. So that is a pro-inflammatory cytokine. So there were higher ratios in the CSF compared with the serum in the first week after brain injury in patients that went on to develop post-traumatic epilepsy versus those that did not. And they also found that these patients, many of them had a variation, so a single nucleotide polymorphism at a particular site in the interleukin-1 beta gene that put them at risk for developing post-traumatic epilepsy and lowered that time to their first seizure. They had the first seizure sooner after severe TBI. So again, showing a supporting role for inflammation in the pathogenesis of post-traumatic epilepsy and potentially the role of molecular and genetic biomarkers to predict who will develop this. So just to wrap things up, again, it's important to keep in mind post-traumatic epilepsy can occur even decades after the TBI happens. There is no preventative treatment to stop someone from developing post-traumatic epilepsy after their TBI. And when someone does have post-traumatic epilepsy, we really, at this point in time, don't have unique treatments for them. They should be treated just as any other and investigated as any other patient presenting to you with epilepsy. We really need more research to understand the mechanisms of epileptogenesis in this condition so that we can develop targeted treatments. And it's very likely that the mechanisms of epileptogenesis after TBI may be common to other types of epilepsy as well. And finally, biomarkers are going to be very important so that we can determine who is at risk of developing PTE and also to help further research studies. And so with that, I will wrap up and have left some time for questions there. I thank everyone.